atopy has said that usually a patient came with some rashes, this is itchy. But here what happened? We itch to rash rather than the rash that itch. That is the best explanation. And all over the world, about 25% of the children develop this, and when become adult, it become 2 to 3%. You may be wondering why. When this infantile period go for adolescent, 90 to 95% of the babies will have a well good clearance of the disease with a mild problems. But rest of them go for continuously having this atopy. That is why adult having only 2 to 3% of adults. As it is a chronic disease, we can expect increase and decrease just like fluctuations. A lot of conditions are associated with emotional. It is one of the best and the worst thing. So adverse effect not only to the patients but are the families as well as we, the treating persons. In the midnight, some relatives come and knock your door. Sir, my son or daughter is not at all improving. That gives a lot of problem. That gives rest of your everything has gone. From the statistical study, it is shown that from the last 2 to 3 decades, a gradual increase in the incidence and activities just because of the industrial pollution and polluted environments. In Kerala, the atopic dermatitis is more in and around Kochi, especially in and around Udyoga Mandal. There is a lot of industrial works are going on. Second one is Trivandrum titanium products. But hilly areas like Pathanamthitta, Idukki, Wayanad, very minimal amounts. In India, 2025 statistics say that 2 to 3 to 4.5% of persons have an increasing trends. So, at least some of the clinical procedures we should keep it in mind. In infantile phase, what is up to 2 years of life, always present with itchy, erythema, oozing, or what we call as wet type of disease. When it go for childhood, the oozing may be very minimal. It shows a dried lesions and what we call it as dried type. And other forms in childhood, always due to irritation, they lick the lips. What is called as lip-lick dermatitis, or what we usually call it as cheilitis. Then infra-auricular area, there is always develop a fissure. That is a constant sign for at least more than 50% of the atopic patients. Then eczema, especially nummular type of eczemas, off and on, it can exacerbate any time. Once the dried lesions persist, it becomes lichenoid in nature. And more than 50% of the children have nipple eczemas, irrespective of genders. You can see that underneath of the, can you appreciate it? Two folds are upcurved, that is called as Denny Morgan fold. And you can see that there is hyperpigmentation of the periorbital areas. Except in neonates, all this has started rubbing their eyes with the doors of the hand. That produces chronic inflammation, hyperpigmentation, what is called as periorbital hyperpigmentations. In adults, always if you touch the palms of your patients, it is always normal. But in case of atopic, always give a warm, moist appearance. That is one of the earliest indications. Now I am going to publish it. And regarding the etiology, it is a multi-discipline etiological problems are there. One is genetic, that I will tell you later. Hygienic hypothesis. The where the textbook says, eat dirt and succor. For one thing, a multi-millionaire in US, he is an aircraft manufacturer. I'm afraid to tell his name, just because of he is afraid of all these infections. So he air conditioned 300 acres of land, everything wherever, and he never go out except in very limited conditions where he used all this നമ്മുടെ കോവിഡ് സമയത്ത് മാതിരിയുള്ള. So unfortunately this person died at the age of 52 with bacterial infection because he never exposed to any infections. For best example, our children after midsummer vacation, when they started their school, they always have a respiratory or type of infection first 2 months because they are exposed to the newer infections. But after 2 to 3 months, everything is secure. So eat dirt and become secure. That is hygienic hypothesis. Another one is immune dysregulations, both T cells and B cells immune dysregulations, and microbial colonization. Then triggering factors, your pet animals, birds, and their dandys, then spider webs, dust, parasites, everything that can. Then B-cell immune dysregulation, IgA in such groups either minimal or absent. So IgA is considered as the policeman or army of the gut to prevent entry of allergic or seems to be allergic. So if there is no allergy is absorbed, there is no activity for IgE. So both IgE and IgA as in a balancing act. If IgA is very high amount, IgE does not have any problem. But vice versa, if IgA is ineffective, all this will activate IgE, which will stimulate mast cells seen in the basophil, monocyls and eosinophil. That's why IgE is always elevated. Pathophysiology. We will classify the pathophysiology or pathogenesis into 4 general main groups: genetically mediated, immune dysregulations, defective or disrupted defense mechanism, and microbiologically mediated. So genetically. So in such genetically mediated persons, the development and synthesis of filaggrin is filamented aggregated proteins. Once it synthesizes, it will break down into micromolecules and it will act as a micro moisturizers and protect your skin, and always your skin is hydrated and it will prevent transepidermal water loss. So in atopy, what happens is this filaggrin is unable to well develop standard or normally, so it cannot disintegrate, no moisture molecules. So along with there is always ceramide. Ceramide is synthetically we are used to keep our skin moist, oily and well maintained, but these two are absent. So your micro moisture molecules are absent, ceramide is absent, skin become dry, and so what happen? A lot of transepidermal water loss, skin become dry, easy prey to the external noxious agents. Second is immune dysregulation. So once these noxious agents come in contact with your skin, what happens? T helper 2 and 1 receptors are highly active. In acute phase, it reaches 2 receptors. They started secreting, activated and secreted interleukin 4, 5 and cytokine. That is in the acute phase. Within due course of time, going for chronic phase, they will induce interferon gamma and interleukin 12. With the activation of Th2 and Th1, release all this pro-inflammatory and inflammatory agent, it induces pruritus. So, we start scratching it. It will remove the stratagonium, it will traumatize the epidermis keratinocyte. Immediately the keratinocyte started inducing inflammatory cytokines like TNF alpha, interleukin 1 and interleukin. So, epidermis is damaged, pro-inflammatory and inflammatory agents are diseased. Then what happens? Your defective defenses, that is synthesis from the skin, which contains defenses such as antimicrobial peptides, they are supposed to act against the bacteria. So beta defense and catalysts are absent. So what happens? The skin is exposed to toxic agents like microbes. As there is no microbial polypeptides, they can very easily infect your skin. And the fourth role, it is microbiological mediator. Your staphylococcus is one of the notorious that they can visit everywhere without any invitation. So very easily they can catch up your skin, especially phase 17 and staph 17 and 16. So what happened? They produce bacterial infection, mild, moderate, or severe. But in neonates, what happened? Staphylococcus phase 17 and 68 that produce staphylotoxin, produce erythema, edema, and staphylococcal scalded skin syndrome. You may not be able to detect it, only toxin you can detect. So the clinical features. First and foremost is pruritus, uncontrolled pruritus. Normally they have the pruritus, but at the moment of emotional outbreak, they started bouts of pruritus, intense pruritus. Then once it started injure the skin, that can produce eczemas. Either it may be acute, carried by oozing, subacute, just dried the oozing, and chronic, no oozing, but it is shows features of hyperpigmentation, lichenification. There is typical morphology along with the age, up to 2 years, mainly seen in the external aspects of the body. What happens in the scare? It is lustralized, straight away, unruly hair. And eyes, periorbital hyperpigmentation, centrofacial pallor, and Denny-Morgan fold. As there is a periorbital hyperpigmentation and centrofacial pallor, as if an ENT person having a headlight, the head, forehead, everything is dark. So what it is called as headlight sign. Then there is infraauricular fissuring, cheilitis and pearlish. Then what happened? Up to 2 years there is extensor aspects is inflamed, not the flexural areas. And in neonates and child, you can see the sides of the neck, it is dark and not beautiful, so we call it as dirty neck sign. And there is always have a chronic and relapsing history, 2 or 3 times in a month or even several months in a year. If a person presented with suspicious of this atopy, there is always a family history. And the simplest test you can do is estimate IgE. I already told you that A is defective, I is and dryness of the skin. Then there is atypical vascular response. In your triple response of Louis, instead of the red, there is always white. That is due to say acetylcholine. It produces intense edema, compressed blood vessel. It gives a white response rather than red response. Then wheals and flare. Once erythemas develops, it takes a lot of time to blanch. That is called as delayed branch response. Then dry skin always produces follicular prominence, elbow joints and knee joints, what is called as keratosis pilaris. And palms, I already told you, hyperlinearity, ichthyosis, nails sometimes you may find pitting and leukonychia. In the eyes, superficial punctate keratitis and allergic conjunctivitis. And allergic rhinobronchitis also there. So these are the clinical presentations. How we, first and foremost, is there is barrier defective. So we have to first try to repair the barrier defect, because once there is a barrier defective, the skin becomes dried and it invites infection, and there is no water, there is no barrier protection. So we have to rehydrate. Either you can use saline compress, one of the isotonic saline compresses, adequate rehydration. So the stratum body is completely filled with water, and it will minimize the direct contact of the noxious agents and allergens. And the barrier function is restored, and it can give very good protective barrier. Second one is wet wrap method. If the patient is having acute eczematous condition, we have to compress either saline or hypertonic saline. Then we have to apply some emollient. But best method, use a sterile Vaseline gauze, mix with topical steroid, apply over it and wrap it with bandages. So once this dried up, again you can sprinkle saline, again reapply it. So you have to complete it to 2 to 3 days. That acute oozing phase is over. Then you can use topical steroids and emollients. Then lukewarm water soaps. They always prefer to have lukewarm water bath rather than cold water or too hot water. That can irritate. Second, as the acid mantle is damaged, and we used to wash our hands. If there is oil in the hand, we use the soap. What is the pH of our soap? Our beauty soaps like Margot, everything is 11 to 15. High alkaline nature, that will remove all the water from the palms and soles. So what happens if you use such soaps in this already dry skin? Everything is removed. Skin becomes further exposed to dryness. And the skin pH is 5.8 to 6.2. And we have to prevent the acid mantle. So we have to use neutral soap. Only and on neutral soap is made by the synthetic detergents. On Curatio, one company is producing the synthetic bag. It will preserve the acid mantle. Entry of the bacteria and other noxious agents is prevented. Bleach bath. If everything has failed, bleaching powder is used to sterilize our water, drinking water. So here we can 1 gallon is 3.7 liters of water with 2 to 5 grams of bleaching powder. So it is a bactericidal agent that can you can reduce the use of systemic antibiotics by you can sterilize it. Then followed by saline bath, because we have to wash out all the bleaching powder. 20 to 40 gallons of saline bath. Immediately after bath, you should give no way to dryness. So immediately after any emollient, so that evaporation you can be very well prevented. That is, advice is that you should apply within 3 minutes. Usually our creams vanishing or ointment base or gels or vegetable oils. Our coconut oil is one of the best thing. Only thing the price factor. Then 10% urea, but it is a double-edged weapon. This urea, it has got a hygroscopic property that it will absorb the water from the environment and give to the hydrate your skin. If the air is dry, it absorbs water from the skin, give it to the air. So it is very careful using this urea cream. Then ammonium lactate. It is usually we used to restore the normalcy of the psoriatic skin. It is very useful in this condition. Then the last one, it is aqua base, is one of our beloved professor from Calicut, Dr. Sudan sir. He used to prepare this. There is he take 30 grams of cholesterol and 70 grams of white beeswax melted in 80 degree. It's one of the best base for using anything. It can act as an emollient also. Then use of cortical steroid, topical steroid. In children below 12 is better to use mild and moderate. Moderate one at present mometasone, fluticasone, betamethasone. Mild clobetasone, butyrate, hydrocortisone acetate. And in infants, you should not use more than 15 per week, 15 gram per week. And children less than 30 gram per week. Duration is at the maximum 14 days, then you have to stop or taper it because the steroid problems. And what happens if the lesions are lichenified, thickened enough? Occlusive dressings are best. You can use occlusive dressing like cordon tape or your porous tape, so it will occlude and moisture is retained there, absorb more and more. Then topical immunomodulators. One is your tacrolimus. It is a calcineurin inhibitor. What happens? It suppresses the release of cytokine from T cells. It inhibits interleukin 3, interleukin 4, interleukin 5, granulocyte, monocyte, colony stimulating factor, and TNF alpha. It always also inhibits the release of preformed from the skin from the mast cells and basophils. It may downregulate the expression of FCE receptor, which will inhibit the eosinophil, basophil, and IgE activation. In children, always better to use 0.03% and adult 1%. If not available, pimecrolimus is one thing that you can give 1%, that is for the infants and children. This pimecrolimus is the one non-steroid cream approved by the US FDA. It is from the Ascomyces streptomyces. It selectively inhibits production, inhibition, and release of cytokine from activated T cells. So, whenever you use this pimecrolimus or tacrolimus, there is always a black box warning. First thing, they have written that no long-term safety has been established. A strong suspicion of malignancy link is not proved or disproved. So, advice to follow, use in patients older than 2. Your tacrolimus, not pimecrolimus, use intermittent not more than 6 weeks continuously. Then better avoid use in immunosuppressed patients. Atypical cases should be take a biopsy before starting this. Then it being a photosensitizer, always advise to use sunscreens. Another one is cyclospore, tolpocladium, inflatum. It's one of the best drugs for organ transplantation, where chronic non-responsive psoriasis, even atopic dermatitis. It acts upon suppress the humoral as well as T cell immunity, calcineurin phosphates, interleukin 2 as well as its receptor, and also it inhibits the histamine release from the mast cells. It is very useful in a refractory type of atopic dermatitis. Once it improved up to your imagination, better gradually stop it, not rapid release that may relapse. Adverse effects like nausea, abdominal discomfort, injudicious use that can go for hypertension, and once it is used for renal transplant, it can take your kidney also. Probiotics. There is a conflict reports that what is the use of, but in our experience it gives a lot of positive energy, like it will rapidly prevent the side effects like bacterial colonization and the opportunistic infections. It is useful in first detect atopy rather than the already atopic patients. Then our coltar, one of our major weapon. It is an anti-inflammatory, anti-pruritic, anti-infectant, and antimitotic. Very useful. Then this is one of the major interest is phosphodiesterase 4 inhibitor. Here it is available as apremilast. It has a lot of indications like Behçet's, your dermatomyositis, all these conditions. But here we can, it selectively target and inhibit phosphodiesterase 4 enzyme, inhibit conversion of CAB level, control inflammation, and it will prevent or almost inhibit the cytokine production. Then how we will try systemic therapy? Most of the time our bacteria Staphylococcus aureus. So sometimes there may be a lot of resistance. How we can? Cephalexin seems to be one of the best, or amoxicillin clavulanic acid. Then a lot of antiviral Kaposis varicilliform infections are also there. We have to do antiviral. Then ultraviolet therapy, UVB broad, but better it is narrow band. Then Sorrel with ultraviolet A. What about antihistamines? Topical antihistamines are advised, but that chance of allergic reaction is more. Antihistamines block histamine, especially it stabilizes the mast cell is ketotifen, astafen. It stabilizes the mast cell, release the histamine, serotonin, kallikrein, kinin, all vasoactive amines. It will stimulate IgE, further eosinophils, basophil, monophil, everything. So it can reversibly control it. Your atarax or then your hydroxyzine hydrochloride, cyproheptadine, everything is very effective. So how we will have a general prevention of drying? Always use creams or solution to prevent the drying. Then woolens, everything, the tingling sensation, normally we felt the patients feel it as pruritus, so better avoid it. Cotton dress is more advised. Use them loose fitting dresses rather than tight fitting. Then one more important thing, if it's children, you just divert their attention if they start scratching it. That can traumatize the epidermis, inflammatory cytokines release. Then detergents, liquid detergents larger than powder fragments may be remain, then that can irritate it. So this is a treatment algorithm, one wet trap method. So that repeated wet trap that prevent drying, traumatization. Then selection of topical steroid. Severe cases you can use potent steroid. Then less severe moderate bile. Then topical calcineurin. Tacrolimus 0.03% in children below 2 years, and if want pimecrolimus and 0.1% in adults. Antihistamines are widely used, helpful for preventing pruritus, block histamine, stabilize mast cells, as well as leukotriene activity, that is montelukast. Antibacterial, we have to prevent antibacterial colonization either by bleach bath or something like that. Then fungus may be there, you have to give antimycotic. If there is streptococcal, you have to give specific treatment rather than staphylococcus. Phototherapy, I already told you, photochemotherapy or PUA therapy, NBV, UVA1. Systemic, only limited cases, because us being a chronic disease, we have to give a lot of, anti-inflammatory analgesics that can take the renal system, everything. Very minimal. Then azathioprine is a potent immunosuppressor. Only limited cases we have tried it, but it is then mycophenolate mofetil. It is also potent immunosuppressor, very limited case. Methotrexate is also limited usage. The biologicals is one thing, fusion protein, everything, that never give a permanent cure. So use with judicious or on your discretion. Apremilas, you know that is. So at the end of 3 months, significant improvements of overall conditions. At the end of 6 months, significant improvement of eczema. So that significant improves in dermatology, life quality index, and eczema area severity index also improved. So the last one, not the least, it is the educational program constituted by the dermatologist, pediatrician, psychiatrist, psychologist, and dietary counseling, because combined effort only can come up the baby. So that's the end. It is notorious. I am an atopic. I know that how much problem I am facing it. Any of you have atopic? Okay, thank you. Thank you for listening. Any query? Come on.
Hello.
Crisaborole are using it for the last 3 years. But one thing, crisaborole is very notorious. Immediately the person can produce irritation, eczema, oozing. So they themselves will tell that before pacify it with hydrocortisone, then gradually apply it. Once it, no, you can use within 2 to 3 weeks of start along with the hydrocortisone. Best report, crisaborole. Only 2 or 3 companies are available. One is Crisnuo, Crisafree or something like that. Very useful. We can use it in psoriasis also, crisaborole.
Any more
How many,
questions?
how many of you have come across with atopy? Yes, please. No, not you, your patients. As a medicine, Prasad.
Relatives or family members?
More than medicinal like us, because I see chronic
For what? Standard growth may because
Chronic atopic dermatitis.
because there is a lot of problem, mental deficiency there, physical deficiency, because these people never go externally because of the fear of that. But it has the council they have did, so they can only prove it because there may be a lot of inhibiting factors are there, mental, physical, everything. They are sitting in the room.
What about the role of biologicals in children?
Biologicals, of course, very good, but the problem is that can give up to the 6 to 8 years after that again recur. The cost of, unless we have insurances, people can't afford it. Best drug, but only thing, it is not an end of the road. That's the problem. Very good. First, we always tell that first treat the parents. We had a couple of occasions that the mother, one case, mother unknowingly tells to their friends that this is the only problem child. That day onwards, that baby developed worsening of the condition. Emotional upset, that is tracking. Another one is brother, another one is father. So we have to treat the psychological treatment for the parents. I have told that if anybody want can copy it. Okay.
Any more questions? Any more doubts? If no more doubts, thank you, sir, for the excellent, illustrative, illuminative talk. Thank you, sir. If no more questions, shall we wind up the session? I invite Dr. Nikhil Adoor to give the gift as a token of appreciation and gratitude, sir.
ഇതിൻ്റെ ആവശ്യമില്ലായിരുന്നല്ലോ മോനെ. ഓക്കെ, താങ്ക് യു.
കൊണ്ടുവന്ന് തരാം സാർ, വണ്ടിയിലോട്ട് കൊണ്ടുതരാം, വണ്ടിയിലോട്ട് കൊണ്ടുതരാം. I invite Dr. Nancy to give the vote of thanks. Sorry. വേണ്ട.
So I continue to offer you talk like this.
Yes.
Of course.
Well,
By talking, I'm enjoying that I can see you or people for talk.
yeah. Always welcome, sir. With Shobana madam.
Okay.
Good afternoon, everyone. As we come to the end of this program, it is my privilege to deliver the vote of thanks. On behalf of our DVL department, I would like to thank wholeheartedly Dr. Sadeep sir for accepting our invitation to deliver a wonderful and lucid talk on atopic dermatitis and telling us about all the practical tips to manage the case and for sharing your knowledge with us. I take this opportunity to thank Dr. Prasant Kumar, Professor of Medicine, for coming and grace this occasion. I thank Dr. Jijo, Department of Pediatrics, and Dr. Lissy, HOD, Dermatology, for making all our help and support in carrying out this program. Thanking the higher authorities, MS Office, and the administration for giving all the guidance and support. I would like to thank the Operation Department, Audiovisual Department, and my beloved colleagues, staff, students for your participation and support. Thanking the Lord for this blessing in this beautiful day. Thank you, sir.
Yes, I know.